much for the introduction, and I hope that I'll be able to maintain your interest during the next half hour or so. First, I have to work out how to advance the slides. So my objectives are to provide a logical approach to the assessment and management of kidney stone disease, to describe the major types of kidney stone, and to discuss management options. And I'd welcome interruptions at any point. And I've said at the bottom that I'd be happy for any participant to use the slide set, and have sent a copy of this slide set to Lloyd Vincent. So my disclaimers are that I'm a UK nephrologist. I did an elective period in Zimbabwe just after independence many years ago, but I have no clinical experience of working in nephrology in Africa. And there are some suggestions that the epidemiology of kidney stone disease is quite different. And some of those suggestions include the suggestion that there may be genetic differences. The literature is complicated because of presentation bias, investigation bias, and reporting and publication bias. And so nothing that I say will be certain, particularly when it comes to the African situation. And I don't personally consider myself to be a world leader, but I did run a metabolic stone clinic and saw numerous patients with kidney stone disease every week for my working life. For many years. So I have lots of clinical experience and a little bit of published research on the topic. So I'm going to go straight into the cases, and my proposal is that I'm going to present you with a series of cases, and I'm going to ask the chair people to collate comments as they come in on the chat box, and then present some information around each type of kidney stone disease. So the first is a 55-year-old man who presents with typical left-sided renal colic. Plain X-ray shows a calcific density in the line of the left ureter consistent with a calcific kidney stone. And the patient works as a taxi driver with no family history of stone disease. He's obese and hypertensive, and on urinalysis there's blood 2+ and a pH of 5. And I'd like you to put into the chat box, which I can't see by the way because of the way I'm screen sharing, what's the most likely stone composition, what are his risk factors, what investigations, and what treatment, if any, you would advise. And I'll leave it to the chair people to feedback those answers to me, and we'll start talking again when I'm asked to.
Yeah, so I would request people to write answers on the chat box, and then you can read those answers right away. So we have an answer from Nahla Nassim, say calcium oxalate. That's the answer.
And risk factors, go on.
Yeah, another one, calcium oxalate, uric acid stone, looks like calcium-based stones. So can we go to the risk factors? Mother stone composition. So there are so many text, phosphate, diet, risk factor, they say phosphate, diet.
For the person who said decreased oral intake, what intake of what?
Sedentary work, high BMI, obesity. So these are the risk factors that people. Okay. Dr. Tomson, can you read the text messages?
Yes, I can. I've worked out how to do that. I'm going to stop looking at those texts for the moment. That's fine. Okay, so this is a calcium oxalate stone. A uric acid stone wouldn't necessarily show, or would be unusual for a uric acid stone to be seen on plain radiology. Uric acid stones are radiolucent. It could be a calcium phosphate stone. That would also be radio opaque. But I've started with the most common type, which is calcium oxalate. And I'm going to give you a few slides on how stones form. So stones form because of nucleation of crystals and then adherence to something within the urinary tract to stop them being washed away by the flow of urine, and then growth by crystal accretion. It's a very complicated phenomenon, and I don't pretend to understand the basic science behind nucleation, adherence, and growth. And there are some very complicated papers that I don't fully understand. But there's something called Randall's plaques, which are calcific plaques that appear on the surface of the urothelial lining, which are clearly important in the genesis of kidney stones. In terms of simple risk factors that the average nephrologist understands, I count myself as an average nephrologist, you need a degree of urinary stasis. If the urine's flowing very fast, there isn't time for crystals to form. You need urine concentration in order for crystals to come out of solution, and you need low flow and there are many other ionic and inorganic risk factors as well. So there are some reports, as I said in my introduction, of racial differences in calcium oxalate stone formation. Old reports suggest that kidney stone disease is much less common in Black people than in white people in Africa, including one report from South Africa. In the United States, the National Health and Nutrition Surveys 2 and 3 showed that the risk of kidney stone disease was substantially lower in African Americans than in people of white origin in that time period. But later studies have shown that the incidence of stone disease is rising in all ethnic and racial groups, but rising fastest in younger African Americans. And there are some small case series of stone analysis from Accra, from Cape Town, and from elsewhere, showing the various different types of kidney stone disease. So you can see from this study from Nigeria that calcium oxalate stones are the most common. So people who bet on calcium oxalate stones in this instance, in this case, would be right statistically. Calcium phosphate is the next most common, a mixture of calcium oxalate and uric acid. And then you can see the other proportions going down to these very rare combinations here. Interestingly, all these stones were of mixed composition, which is something that I don't fully understand, because in most series from Europe, most kidney stones are a pure composition of one form or another. And I don't really understand whether that's a methodological issue or a real clinical observation. This is another paper from Ghana and South Africa, again, showing mixed kidney stones, but the majority being calcium oxalate. Historically, most accounts of stones were of stones in the bladder, and it is undoubtedly the case that bladder stones are more common in poorer populations with high carbohydrate, low protein diets. Kidney stones appear to have increased in incidence alongside increases in salt and meat intake, and are much, much more common in my clinical experience in a privileged Western society. But the reason that bladder stones form in those people with relatively less rich diets is not clear to me. And it's not clear to me whether the bladder stones form in the bladder or originate in the upper urinary tract. In Western practice, most of the kidney stones we see in the bladder have originated in the upper urinary tract, because we can see the same stones further up in the urinary tract. But there may be a different type of pathogenesis where stones form in the bladder, and I know nothing about that and can give you no useful information on it. The biochemical risk factors for calcium oxalate stone formation are a high urine calcium and a high urine oxalate. That's fairly obvious. The more of those two ionic constituents that are present in urine in high concentration, the more likely crystals are to form, grow, and turn into stones. Citrate reduces the bioavailability of calcium, and therefore a low urinary citrate increases the amount of calcium available for crystallization. Magnesium inhibits calcium oxalate crystallization by slightly more complex means that I won't try to explain. Obviously, the more concentrated the urine, the more likely stones are to form, and a low urinary TAM-horse4 protein also is a biochemical risk factor for kidney stones, but not one that we can easily modify. In terms of what the personal risk factors are, a person who has a high animal protein intake, a high salt intake, a low fluid intake, and a low dietary calcium intake are all more likely to form calcium oxalate stones, as are people with a high dietary oxalate intake and a low dietary fiber intake. I will come back to the reason why a low dietary calcium intake is a risk factor for calcium oxalate stones. But if I give you one message and one message only, it is not good practice to advise people who form calcium oxalate stones to reduce their calcium intake. It will, if anything, increase their risk of forming oxalate stones. I'll give you a brief explanation now. A low dietary calcium intake effectively increases the bioavailability of oxalate much more than it decreases the bioavailability of calcium. And oxalate intake has oxalate availability has a major impact on the risk of kidney stones. These are the epidemiological data from which I've drawn most of those risk factors, and they're all post hoc analyses of the longitudinal studies of nurses and health professionals, so mostly women in the first study and mostly men in the second, mostly done by a chap called Gary Curhan from Boston. Because these surveys included long-term observation and lots of collection of risk factors, they were able to analyze the effects of all these different dietary variables on the risk of forming calcium stones. So a high urine calcium is the commonest abnormality found in patients with calcium stones, and it's the most difficult to treat. It's normally caused by a number of risk factors, including genetic factors that are becoming more and more understood with every passing year. It's important to exclude hypercalcemia with overspill hypercalciuria, for instance, hyperparathyroidism and sarcoidosis, because those diseases are easily treatable and important treatable causes of kidney stone disease. But the majority of people who form calcium oxalate stones, in Western practice at least, don't have hypercalcemia. There are rare monogenic causes such as dense disease, which you may have learnt about in medical school or in postgraduate training. I've seen in my specialist career as a stone physician 2 patients with dense disease over a long period of time, so don't expect to see it commonly. If you read US textbooks, some of them advise complex investigations which involve test diets and lots of urine collections before and after these diets to differentiate different types of hypercalciuria. And those experts may well have something, but I don't know of any good evidence that the phenotype is reproducible or that it predicts response to therapy. So I have never bothered to do those complex investigations to investigate the different types of hypercalciuria because it has no impact on my practice. Thiazide diuretics remain the best therapy to reduce urine calcium excretion and are the bedrock of therapy. This is a recent, and I think the most recent available meta-analysis of thiazides in stone prevention. It's not something on which many people are doing trials these days, but there is established evidence that thiazides in the doses in these trials that were successful, i.e. quite high doses, benflumethiazide, for instance, 2.5 milligrams 3 times a day. That's 3 times the dosage used for hypertension, or chlortalidone 25 to 50, result in reductions in stone recurrence rate over time of up to halving. So thiazides are certainly worth considering if you're stuck. Hyperoxaluria is the other main metabolic risk factor for calcium oxalate stone formation, and oxalate metabolism is complicated. I did my research thesis on this, and I've listed some of the ways in which an increased urine oxalate may occur. For standard calcium oxalate stones, it's probably most important to consider GI absorption. Primary hyperoxaluria is very rare. B6 deficiency has never been shown to be an important contributor to calcium oxalate kidney stones in the West, at least. But there are lots and lots of vegetable sources of dietary oxalate. And as I've said earlier, low luminal calcium concentrations increase absorption of oxalate from the diet, as does fatty acid malabsorption and bile salt malabsorption, topics to which I'll return. And as I said, the third major biochemical risk factor for calcium oxalate stone formation is a low urinary citrate. And this is because citrate effectively combines with calcium and stops it being available to form ionic crystals with calcium, with oxalate. And hypocitraturia may occur for no obvious reason, either idiopathic, may occur in acidotic states, including distal renal tubular acidosis and systemic acidosis, and may occur in potassium depletion, diarrhea, and malabsorption, and in high protein, low alkali diets. And some thiazide diuretics may contribute to hypocitraturia, but that's a complex topic. And the treatment is that of the underlying cause or citrate supplements, which have been shown in randomized controlled trials to contribute to a reduction in stone formation in calcium oxalate stone forms. So treatment of idiopathic calcium oxalate stones, as in our taxi driver that I mentioned earlier, are water, dietary sodium chloride restriction, thiazide diuretics, citrate supplements if you choose. There is one trial showing that allopurinol is of benefit for reasons that are complicated, and there is no benefit from dietary calcium restriction. I chose his occupation as a taxi driver because taxi drivers habitually spend lots and lots of time behind the wheel and can't afford to get out of the car to pee, to pass urine, and so habitually have quite a low fluid intake. And so a sedentary occupation with low fluid intake is a certain risk factor for forming this type of kidney stone. Let's move on, if I may, to case 2. So this is a 47-year-old woman presenting with right flank pain, fever, rigors. She has no dysuria or urinary frequency. She's thin. She has normal blood pressure, She has a history of recurrent urinary tract infection since childhood, and she has alkaline urine with protein nitrites and leukocytes on dipstick urinalysis, a raised C-reactive protein and white cell count, and a raised serum creatinine. And plain radiology shows a staghorn type calculus in the right flank. What's the most likely stone composition here, and what's the most appropriate management?
Dr. Tomson, I think you can see the results. You can see the text message.
Yeah.
From the chat box. Struvite stones.
So I'm seeing cystine, I'm seeing triple phosphate struvite, I'm seeing phosphate stones. The treatment is PCNL, surgical removal and treat UTI, infectious struvite stones, magnesium, ammonium phosphate. So most people who've responded have responded correctly. Thank you for that. This is a struvite stone, magnesium, ammonium phosphate. And the clues to that are the systemic infection. It could be a cystine stone, although it wouldn't be so obviously radiolucent. And I chose a very simple case to exemplify that this type of kidney stone forms in the presence of urease producing organisms causing chronic urinary tract infection. And by splitting urea to ammonia and other substances, they cause an alkaline urine, hence the urine pH of 8. So an alkaline urine together with fever and together with these symptoms is highly suggestive of an infection stone. And as some of the respondents correctly observed, this is a complicated disease to treat because unless you clear the stone, you won't clear the infection. And unless you clear the infection, further stones will form. So treatment is a combination of stone clearance and antibiotic treatment, some of which may be prolonged. It is possible and has been tried in the past to administer drugs that inhibit the ureases that are formed by this type of organism, but they make your hair fall out, they cause other side effects, and I've never seen them used in Western clinical practice over 30 years. It is important to say that not all staghorn stones are struvite. And I once saw somebody, for instance, with staghorn calculi looking a bit like this on plain radiology, whose calculi were caused by calcium oxalate stones in the context of genetically determined primary hyperoxaluria. And the diagnosis was delayed because people sprung to the wrong conclusion and assumed that these were infection stones. And the diagnosing primary hyperoxaluria late is a very bad mistake to make, because it can cause irreversible kidney failure. So these are infection stones. Let me move straight on to the next case. I'm aware of the time. So our next case is a 55-year-old man who's morbidly obese and hypertensive, and he presents with fatigue, breathlessness, and loss of appetite. His urinalysis is pH 4.5, so an acid urine, and 2+ blood. And he has marked renal impairment with some degree of renal anemia, and no abnormality is seen on plain radiology, but you manage to get an ultrasound that shows bilateral hydronephrosis and a non-contrast CT. And I'm aware that I'm speaking to an audience that may find access to the non-contrast CT very much more difficult than it is in the West, but a non-contrast CT shows bilateral kidney stones at the PUJ. Again, what's the likely stone composition, immediate management and long-term management? And the answers are coming in thick and fast, and most people are saying uric acid. Somebody has said calcium oxalate, which is less likely because the stone was radiolucent on plain radiology, where calcium oxalate kidney stones are radio opaque, particularly if they're big. So these are uric acid stones. I've also noticed there are some questions in the Q&A, and I'm going to return to those in a minute. So the likely stone composition here is a uric acid stone. And I say that because uric acid stones form in patients who form concentrated acid urine. And I gave you clues that the patient had acid urine. They're common amongst patients with ileostomy, but also common amongst patients with obesity and metabolic syndrome. And that's why I chose this illustrative case. The reason is that people with obesity and metabolic syndrome have defective urine buffering, and produce much more acid urine than would otherwise be the case. We don't know why that is. Well, I don't know why that is, and I've never read a paper explaining why it is. And I think it's still a topic for active research. But it's a matter of fact that people who are morbidly obese are likely to have very acid urine. And very acid urine is the most important risk factor for uric acid stones for reasons that I'll show you in just a minute. So the treatment is by making the urine dilute and alkaline. And the treatment, therefore, is a mixture of water, sodium bicarbonate, or potassium citrate. And reduction of uric acid production by allopurinol or febuxostat or something like that is of secondary importance only. And the reason for that is this classic slide from an old paper from KI. And this is the limit of solubility for uric acid at various different urine pHs. So you can see that you can have more or less any concentration of uric acid in the urine that you want, so long, and it won't be insoluble if the urine pH is 6.5. Whereas at 4.5, even a very low total amount of uric acid will result in uric acid supersaturation. So this is very straightforward inorganic chemistry. And if you read for uric acid stones, this is all you really need to know. If you can make the urine pH 6.5, the kidney stones will stop forming. Now, it is true that alkalinizing the urine increases the risk of the formation of some other forms of kidney stones, particularly calcium phosphate stones, which form preferentially in alkaline urine. So there is a balance to be made here. But effectively, the more alkaline the urine, the more likely it is that uric acid stones will dissolve on their own. And indeed, this is one of the very few types of kidney stone where medical therapy can result in stone dissolution. And I show you that in this slide, which is a slide in the patient who had an ileostomy, not seen on this section. This was before and after a period of treatment with sodium bicarbonate. I think about 6 months from memory, and the kidney stone more or less completely disappeared over that time with no other intervention. So it's a very satisfying disease to treat. Case 4 is a 38-year-old woman who presents with typical left renal colic. She has a past medical history of multiple ileal resections for inflammatory bowel disease, but the colon is intact. A radiopaque stone is seen on KUB, and that's confirmed on a non-contrast CT. She's very thin. She is hypotensive with a postural drop, and she has a urinalysis of pH 6 and blood 2+. And again, I'd welcome your comments on the likely cause in this patient and the optimal long-term management. And again, the answers are flooding in, and nearly everyone has said calcium oxalate, and you're correct. And the long-term management of a patient like this, does anybody have any suggestions about how you might reduce the risk of further recurrences of calcium oxalate stones in this patient with enteric disease?
At least is a focused tips. And then kwa hawa wadau ukiwaalika, usually huwa wanataka ile theme yao iwe kama vile imebobea kwenye mkutano.
Hello, can somebody mute their mic, please, from the attendees? You are interrupting the session.
Okay, so far, take a lot of water. Let me move on to the presentation that I've made for you for this. So this is a classic case of enteric hyperoxaluria, in which ileal disease leads to hyperabsorption of oxalate in the colon. And the pathogenesis is complicated, but summarized here. Calcium soap formation with malabsorbed fatty acids means that the calcium comes out of solution. And as I've said earlier, the less calcium in the colonic lumen, the more easily oxalate is absorbed. It's also a fact that malabsorbed bile salts cause an increase in colonic permeability to oxalate. And there may well be other contributing factors, including B6 deficiency in some patients with enteric disease, and the absence of an important organism called Oxalobacter formigenes, which is an organism that metabolizes oxalate in the colon and therefore reduces its bioavailability. There are a large number of different types of gut disease that can cause this type of enteric hyperoxaluria. And in my clinical practice, it was one of my favorite diseases. I got very interested in it, but never published anything very useful on the topic. This is if you want one review, a very good up-to-date review, I don't know whether it's freely available, but I think it might be. But this diagram summarizes the main pathogenic mechanisms with increased free fatty acids resulting in low calcium, resulting in an increased amount of soluble oxalate, and bile acids, as I've said, increasing oxalate permeability. With low B6 also may be contributing. And it's a nasty disease and can cause kidney failure, and often is clinically silent if it causes just nephrocalcinosis. So if you're not looking out for it, I've seen patients with pancreatic disease turn up in the dialysis unit with kidney failure when they could have been seen coming if they were lucky. So the therapeutic options, if you can do something about the fat malabsorption, you should do that. So if the person's had a jejunal ileal bypass for obesity, which I imagine is very rare still in Africa, but increasingly common in overprivileged countries, a reversal of the operation may result in reversal of the tendency to form kidney stones. Bile acid sequestrants are effective but very difficult to take. Dietary fat restriction is even more difficult to achieve. Dietary oxalate restriction is obviously the right answer, but very difficult to achieve in practice because it doesn't just involve the avoidance of several very high oxalate foods such as strawberries and raspberries, and rhubarb and spinach, but involves the restriction of lots and lots of moderate to high oxalate foods, including such things as wheat bran and many, many others. Increased fluid intake is important if feasible, but in patients with very short gut, that may just increase colonic fluid production and may just worsen diarrhea, so can be complicated. In theory, calcium carbonate, sevelamer and aluminium hydroxide will all bind oxalate in the colonic lumen, and I've used them in clinical practice with some success, but without any clinical trial evidence. Nobody's done a trial on this. And there is going to be new availability of enzyme treatments that effectively allow oxalate oxidase or oxalate decarboxylase to be released in the colon and to destroy the oxalate before it is absorbed. Case 5 is a 22-year-old woman presenting with left renal colic. She has radiopaque stones in both pelvises, plus 2 in the line of the left ureter. She's standard weight with a standard blood pressure. She has a pH of 8 on urinalysis, but no signs of infection. And she has a slightly low potassium, a slightly low serum bicarbonate, and a slightly low serum phosphate on routine chemistry. And again, I'd like to challenge you to ask what the likely stone composition is and what further investigations you might undertake. And this is indeed, you don't need me to give this talk, you know it all already. This is indeed designed to illustrate a calcium phosphate stone forming in a patient with distal renal tubular acidosis. What would be the simplest test to diagnose for certain renal tubular acidosis in this patient? Does anyone do urine acidification tests with ammonium chloride, for instance, or is there a simpler way of diagnosing the disease? Actually, you're right, Dr. Alam. In this case, a urine pH combined with systemic acidosis would get you the diagnosis without any further tests. I've made it too easy. If this was partial distal RTA and the serum bicarbonate was normal, the choices would be between a urine acidification test, which involves 7 grams of ammonium chloride, which is really difficult to take, or a furosemide and fludrocortisone acidification test, which is a very simple way of testing urinary acidification. And in terms of the management, what would the management of this patient be? Well, I'll move on. Most calcium phosphate stones are due to hypercalciuria, but calcium precipitation depends on urine acidity, and so calcium phosphate crystallization is pH dependent and more likely in alkaline urine. So calcium phosphate stones may form simply because of hypercalciuria, but if you find a calcium phosphate stone, and this is assuming nearly certainly incorrectly in many of the settings in which you work, that stone analysis is available to you, you should at least consider renal tubular acidosis and hope for a person with treatable renal tubular acidosis, because the genetic causes are by definition irreversible, and stone formation in such patients is difficult to treat. these are relatively uncommon. The acidosis causes hypercalciuria, but you also get phosphate wasting, decreased citrate excretion, and alkaline urine pH. And treatment really comprises maintaining as dilute a urine as possible, reducing urine calcium, if relevant, with a thiazide, and possibly citrate supplements. Let me move on to the final case, which is of a 25-year-old woman presenting with multiple episodes of kidney stones since childhood. There was no family history of kidney stone disease, and there are no stones seen on plain radiology, but on unenhanced CT, there are multiple bilateral low-density kidney stones with moderate right hydronephrosis. And this patient undergoes flexible ureteroscopy and laser treatment, and the urologist reports a rotten egg odor during stone treatment. I'm giving you all the clues necessary for the diagnosis of this, which I understand to be a relatively rare condition in Africa, but from your reading, what's the diagnosis here? And out of interest for me, would anyone say whether they've seen cystinuria in their clinical practice in Africa? Because I'd be very interested to hear about it. And you should be interested too, because nobody has yet reported a case of cystinuria in Africa. And none of, yeah, okay, well, Mazai should write it up as a case report at the very least, in my opinion, because it's said to be vanishingly rare, and none of the case series that I found have yet seen cystinuria. And I suspect that's because it's a difficult diagnosis to make and to treat. But anyway, thank you for those answers. That's made my day that some of you have seen patients with it. So this is cystinuria. It's caused by an inherited abnormality of the reabsorption of cystine back into the body, leaving diabasic amino acids in high concentration in the urinary space. And there are two different mutations that can affect one of the two different cystine transporter subunits. And one of my only major contributions, or my only contribution to stone literature, was to collect a large number of patients with cystinuria and get DNA from them in combination with a colleague of mine in Newcastle who did the same. And we found no genotype-phenotype correlation at all, which is disappointing and tells us that there's much more to do to understand why people form cystine stones and what their risk factors are. Cystine is highly insoluble, especially at acid pH. Its excretion is linked to sodium excretion, and the diagnosis is made by measuring urine cystine and by stone analysis. There have been very few recent advances in the treatment of this condition, and the treatment is largely with water, dietary sodium restriction, because as I've said, a high sodium intake increases the amount of cystine that's excreted, and trying to maintain a neutral urine pH. Not alkaline, because alkaline urine pH will increase the risk that calcium phosphate will precipitate on top of the uric acid stones, which will act as a nucleator for calcium phosphate stones, and then you'll be left with two different types of stones, which is more difficult to treat. But if you maintain the urine at around pH 7, you've got the best chance of causing stone dissolution, or at least reducing the risk of or the rate of further stone growth. Some people suggest a low cystine, methionine, or low protein diet, and there's no proven evidence for that, but it makes some biological sense. And often one relies on chelating drugs such as penicillamine and tiopronin, both of which chelate cystine in the urinary space and prevent its ability, or reduce its ability, to combine with itself to form cystine crystals. Penicillamine and tiopronin are both unpleasant drugs to take, which, as you know, both can cause membranous nephropathy as well as other complications in the skin and elsewhere. And so the management of these patients requires fairly intensive follow-up. My last case, I hope I'm doing all right for time, chair people, but please tell me if not, is a 15-year-old boy who presents with renal colic. He's had numerous similar episodes in the past, but most of these were passed off as bellyache in a small child. There's no family history, and he has multiple bilateral calculi demonstrated on plain radiology. And I'm afraid I'll skip straight to the diagnosis, and so I won't put you through the trouble of asking asking you to tell me what these are. This is to illustrate primary hyperoxaluria. There are 3 different types. Type 1 is the most severe, type 2 is less severe, and type 3 is less severe again in terms of their phenotype. Type 3 is probably the commonest, type 1 the next commonest, and type 2 really quite rare. Reviews are in the slide, in the references that I've given you there. And the treatment of this rare condition is of a high fluid intake, citrate supplements, particularly if hypercitraturia is present, Thiazides if hypercalciuria is present, or possibly even if it isn't. Old reviews mention phosphate supplementation, for which I can find no empirical evidence, but there's a little bit of logic to that, and magnesium supplements, because as I said at the beginning of the talk, the more magnesium in the urine, the less likely calcium oxalate kidney stones are to form. But again, nobody's done any form of trial or even case series to show that magnesium reduces stone recurrence in this disease. In the Western world, we've been lucky enough to be allowed to offer liver transplant to these people. And there is now, as of earlier last year, a liver-directed interfering mRNA treatment, which is astonishingly expensive, at least now, which is effective in reversing the phenotype of type 1 primary hyperoxaluria. So that's very exciting for the future. Those are all the slides that I have for you. And in summary, kidney stones are likely to become more common as dietary and personal habits change in African countries, as you become richer and as people adopt a Western lifestyle with a higher animal intake, animal protein intake and salt intake. Management depends on the stone type. If you can get a stone analysis or guess at stone analysis from the clues that I've given you, although all types of kidney stones benefit from a higher water intake, dilute urine and a high urine flow. So nearly always the answer is drink more. And there have been no published studies on the frequency of any of the genetic causes of stone formation in Africa. And if anyone is interested, please email me at the address below, and I'll put you in touch with a colleague of mine called John Sayer in Newcastle, who is a geneticist who works in as a nephrologist. So he's an interest in genetic kidney diseases, and he'd be very keen to hear from potential collaborators who would wish to do work like that. Thank you very much for your attention, and I'm now happy to take questions. And the first one I can see is any role for vitamin B6. There is a role for vitamin B6 in type 1 primary hyperoxaluria in people with some genotypes, but not others. It depends on the mutation, Dr. Alam. And effectively, you have either to know the exact genetic mutation and then have that predicted for you by the lab, whether or not vitamin B6 in high doses will be partially effective. Or you do a trial of treatment. There's no proven role in the treatment of hyperoxaluria outside of the genetic conditions. Will cysteamine treatment form with reducing stone formation? Not to my knowledge. Captopril has been used with case report evidence of success, but it's pretty difficult to use and not very effective compared to the other treatments. Looking at the Q&As, how much fluid in 24 hours should patients with kidney stones be advised to take? As much as possible, and it really depends on the lifestyle. And for cystine patients, you can answer that more or less with some mathematical accuracy by looking at their 24-hour cystine excretion and then working out how much fluid it would take to bring their cystine excretion down below the target range. But 3 to 4 litres is sometimes achievable. Most patients find that getting up 3 or 4 times at night to pass large volumes of urine to be intolerable. So it's as much as you can get people to do, really. And what size of kidney stone should be referred to urology for removal? I should know the answer to this question. And I think it will depend on your local urology service and what they will accept as a referral. I think 5 millimeters. Below 5 millimeters, kidney stones can pass fairly easily. But I can't give you a straight answer to that question. And the last question is, how does sodium chloride restriction help in the treatment of calcium oxalate kidney stones? And again, I can tell you that a high filtered load of sodium chloride increases calcium excretion in the urine. But I can also tell you that sodium bicarbonate does not have the same effect. So it has to be something to do with the anion as well as the cation that a high sodium diet increases calcium excretion. And the exact physiology is something that I'm not sure that I'm able to share with you, but I'm going to show you one slide by stopping sharing and answering and opening up a different presentation, if that's okay with the chair people.
It's very okay, Dr. Tomson.
Okay. In the meantime, any verbal questions, or is there anything else that I should be answering?
Yes, we have another few, like 2 questions from the chat box.
Yep.
New ones.
Let me just, I'm just going to see if I can open this, this one. Sorry, I'm getting stuck with slide sharing. So here we are. So to answer the question about urine and sodium, all I've said in this illustrative slide from a review we did several years ago is that urine calcium is increased by high sodium excretion. But I don't think I can give you a precise and convincing explanation. So I'm going to minimize that for now. Oh, stop share. Okay, in the chat box, what other questions do we have? Would use of allopurinol? Well, for the reasons that I showed you earlier about the pH dependency of uric acid in urine, allopurinol and phosphate might help a little bit, but it's certainly not anything like as effective as alkalizing the urine. Because as I showed you in that slide with all the different lines going across at diagonal in different gradients, the only thing that allopurinol or phosphate would do would be to reduce the amount of uric acid in the urine. But if the urine pH remains at 4.5, then you could reduce it threefold and you'd still have an increased risk of uric acid crystallization. I don't know about disodium hydrogen citrate. Any form of citrate would work. I haven't come across disodium hydrogen citrate, but effectively anything that will increase citrate presence in the urine would help to reduce the risk of calcium oxalate stones. I don't know about medical expulsion therapy. It's a urological topic. I seem to remember that there was a large randomized controlled trial that showed very little effect of alpha blockers or calcium channel blockers. And I don't think they're indicated for every kidney stone. But I haven't prepared an answer to that question, and I can't give you a clear answer. A good challenge, Dr. Raphael, thank you. If you email me at the address I gave you below, I will try and find that question. No, find the answer to that question. Recommended dose of hydrochlorothiazide. Well, if you look back at the meta-analysis, 50 milligrams was the dose used in the trials. So 25 probably wouldn't be good enough. What can we use to acidify urine? And you wouldn't want to acidify urine in patients with calcium phosphate stones. You can, but it's not of any proven benefit. In patients with calcium nephrolithiasis as a result of hyperparathyroidism, I would recommend parathyroidectomy in this country. Whether or not that's available in your parts of the world, I'd like to know the answer. Please let me know if anybody has an opinion on that. But I think somebody who's had medical complications from hyperparathyroidism and has proven hyperparathyroidism would qualify in this country for undergoing parathyroidectomy, or at least partial parathyroidectomy. And the potassium citrate, for us, well, that's a good question, Marie. You really go on with these treatments so long as the patient remains at increased risk of kidney stones. And for many patients, that's lifelong, but many patients won't accept lifelong treatment, so it's as long as the patient will tolerate. But this is a disease of years of evolution rather than months, and to even see success from thiazide treatment, the trials needed to be 2 or 3 years, which is why they're unlikely to be repeated. And the same for citrate. it takes quite a while for a kidney stone to grow and form, and therefore quite a while for you to know that your therapy has been successful in stopping such kidney stones forming. In answer to the question about cinacalcet, yes, that probably would be an alternative to parathyroidectomy. Again, I don't know if it's available widely in Africa. It's an expensive drug in the UK at least, and parathyroidectomy is a more definitive form of treatment for primary hyperparathyroidism. Particularly, if it's a single functioning adenoma and you can leave the other 3 glands in place, then surgical parathyroidectomy is, in my opinion, a better treatment.
Okay, I think we have exhausted all the questions. Thank you so much, Dr. Tomson. I can see there's one, Dr. Mbarubuke has raised a hand. Maybe you wanted to comment or ask something. From the panelists, anybody wants to add an addition or?
Hi, Dr. I just want to say from the pediatric side, Dr. Tomson, stone disease is pretty rare in children, okay? Yeah. I think I've only seen about 3 children so far with stone disease. I know it's quite common in certain parts of the USA, like when I went to do an elective in Chicago, they had a whole stone clinic because they see a lot of patients with dense disease and other genetic forms of, renal tubular acidosis. So they see a high incidence of stone disease, but not us.
And why do you think that is, Dr. Verma? Do you think that's because of the availability of the investigations that are necessary to make the diagnoses, or do you think there might be a real genetic difference? You know,
I think it's a combination of both factors.
Yeah.
I mean, we will only diagnose it if it was strongly suspect or you picked up on an oxalosis on a routine X-ray or something. You know what I mean?
Yeah. Yeah.
But nobody actively goes and does a whole screen for stone disease.
No,
no. Because it's quite uncommon, and your pickup rates for the amount of money you're going to invest in it is very low.
Yes,
so it's not going to be a very fruitful exercise in that sense. You see, but I must say we've seen patients with oxalosis, and we got one patient with cystinosis. We haven't seen any dense disease. Yeah, that's cystinuria.
Cystinosis or cystinuria?
It was cystinosis, not cystinuria.
Right. Okay. That's a horrible.
And then oxalosis we've seen 2 patients. See.
Yeah.
But I must say, and I've seen one child, a white child, who had calcium oxalate stone, but then he had fracture of his leg and was immobilized for quite a while, and he was not someone who drank a lot of water, etc. So we had quite a few predisposing factors.
Yeah.
But it's pretty rare in children, I must tell you. It's something that will make a grand round presentation for us. Yeah. Okay, thank you. Yeah. Thank you for that excellent talk. I really appreciate it.
Well, it's a pleasure. I've emailed the PowerPoint presentation. It doesn't need to be a PDF. You're welcome to use the slides and adapt them for your own purpose.
Oh, thank you very much.
If Dr. Lloyd Vincent is happy to.
He'll send it to us. Thanks.
That's great. Well, thank you so much for listening. It's been this might be the last lecture I ever give in my career, because I'm largely retired, but I've enjoyed it immensely. And thank you for all your feedback. And I'm sorry I couldn't answer all of the questions.
So thank you so much, Dr. Tomson. Thank you, everybody. And I would like to end our webinar now.